All right, so it's 1:30. We're going to start with today's UAC webinar, where we have the pleasure to have with us Nikolaos Kavalopoulos from the Department of Medical Biochemistry and Microbiology here at Uppsala University. First of all, say thank you to all of you that have joined us today on a week where a lot of people are on holidays and where we have in some places shorter weeks, either by Friday or holidays on the Tuesday. So thank you so much for being with us. And today we're going to talk about or learn about antibiotic combinations. Nikos is going to tell us a little bit about the current state of antibiotic combinations in the clinics. He's going to talk about the work that they have been doing with diagnostics, including antibiotic combinations. And above all, why sometimes, when 2 and 2 in antibiotics doesn't really equal 4. So what is happening in there? The talk is going to be about 40 minutes. We have scheduled a full hour for the webinar, so we will have ample time for discussions after the talk is done. Nikos, are you okay if people also maybe ask questions meanwhile, just in case something is unclear as we're going on?
Yeah, sure, of course.
Yes, and also have in mind that this webinar is being recorded. So if you don't want to put up your hand to ask a question with your mic on, you can always write your question on the chat, and I will I will speak it up for Nikos as well. With that, I will start sharing my screen and give you the stage, Nikos, for your presentation. Thank you so much.
Thank you, Eva, for making this whole thing happen. Let's start sharing the screen once again. All right, can you guys see my screen?
Correct, yes, all good.
All right, the correct screen also, I suppose.
Yes.
Okay, good. So hello, everybody. I am Nikolaos Kavalopoulos. Eva did almost a correct pronunciation on that. And I am a biomedical researcher here in Uppsala University in IMBIM, and I am also chief scientist in RX Dynamics, a newfound diagnostics company here in Uppsala. And today we're going to be talking about antibiotic combinations, and more specifically, the curious case when 2 + 2 does not always equal 4. So to get things started, when we think of antibiotic therapy, we often think of this pipeline. So first of all, medical professionals or us ourselves detect signs of infection. We go to the hospital, they say, yes, you have an infection. They identify the pathogen, the strain that causes this infection. Then through various methods, either quick or slow, there's a susceptibility study on it to determine which antibiotics work and which doesn't. And then the holy grail of this is we choose the best possible treatment of a single antibiotic that would treat this the best. However, this kind of simplistic pipeline is not true, even at all, because at any single point in this diagram, antibiotics are prescribed, even often without any other information, and not always single ones, but many times they're actually multiple ones put together. So our focusing on this straightforward pipeline has kind of driven us off the clinical reality, which is that antibiotics are very often prescribed and given in combinations. And when I mean combinations and often, it is actually kind of like this. So for bacteremias, surgical site infections, or pneumonias, 50% of patients will get antibiotic combinations. More than half of patients that suffer from septic shock in the ICUs will get a cocktail of antibiotics. And almost all patients that have cystic fibrosis, endocarditis, osteoarthritis, or tuberculosis will actually get multiple antibiotics at once. And this very interesting metric, I think, is that if we look in a hospital setting, 50% of the total volume of antibiotics coming out of hospitals are actually given in combination. So for every 2 grams of antibiotics prescribed in hospitals, 1 is given in combination with something else. So needless to say, antibiotic combinations are here to stay, and they are very, very much used. And that is because intuitively they are very appealing. You don't need to be an expert to understand with common sense that if you combine 2 antibiotics, you attack a pathogen from 2 different approaches, 2 different ways, and that way you broaden your coverage. you cover all bases, so to speak. And it also provides an insurance against not yet detected resistance. So if you want to give a treatment before you have any more information, it's good intuitively to include multiple antibiotics, because in that way, in case your strain is resistant to one, maybe the other one would take over and it would still act. So intuitively, they're very good, and that's why we use them a lot. But what we noticed by using them extensively in the clinic is that there's a big variability in the same multitherapy applied to different patients. So from patient to patient, from bug to bug, they seem to be responding differently to the same multitherapy. And antibiotics that are given in combination are chosen based on empirical rules and dogmas. So no data-driven guidelines to this. Every hospital says, oh, these are the 2 antibiotics we've been giving for this. These are the 2 we continue to give, empirically and dogmatically, so to speak. And right now, in the hospital setting, there is no testing for what we call combination efficacy or antibiotic interactions. And what do I mean when I say interactions? Antibiotics are chemicals that act on living things, the bacteria, and therefore they interact in this aspect of them. And you can have 3 different kinds of interactions. You have antagonisms, where the total effect of a drug combination is smaller than the sum of each individual drug. You have additivity, where you just add an effect on another existing effect. And you have synergy, which is the thing you would most likely want to get, where the total effect of a drug combination is larger than the sum of its parts. So additivity is the very simple case of 2 + 2 = 4. That's easy to understand. Synergy is the paradigm of 2 + 2 = 5. So together, they're slightly more efficient than individually would have been. And antagonism is 2 + 2 = 3. So again, intuitively, if you're in additivity, you're fine. Synergy is something you want to aim for. You want to get better effects from the combinations you are creating and developing. And antagonism is something you want to avoid, because this is doing less than what you would expect. There is also an extreme case of antagonism where 2 + 2 would = 1, called suppression, where by giving the second antibiotic, you're actually taking away effects from the first one alone. And that is something you absolutely need to avoid. So armed with this knowledge, we can now address the first question, which is, okay, we're doing combinations. Why are we not seeing overwhelming positive effects of combination treatments when we look at them? And the answer is the way we study antibiotic interactions is very different than the way we study single antibiotic effects in a clinical setting. First of all studies are patient-driven data studies. So retrospective clinical studies in the form of, if this many patients got antibiotic A, this many got A and B, which cohort, which group responded better? And of course, multiple of those have been done for many years, and they are sometimes contradictory. Sometimes they find that combination therapy is better over monotherapy. Sometimes they find the exact opposite, that monotherapy is better than combination therapy. So it's a mixed field, and it's very much dependent on where you are in the world. And it seems like there's no conclusive evidence on why a combination therapy is good or bad in the way of clinical studies. And the way to understand why that is the case is if we try to draw an analog with the way we do monotherapy studies. So assuming all I wanted to do was to study the effect penicillin has on the treatment of E. coli. And the way I do it is the way we commonly look at combination effects, which is a clinical study, a cohort retrospective clinical study. So I look at 10 patients from Greece, and I see that for 6 of them, penicillin didn't work. And I look at 10 patients in Sweden, and I see that for 4 of them, penicillin didn't work. So naturally, what conclusion anybody would get from this is that penicillin doesn't work reliably against E. coli pathogens, which of course is wrong. We know that as a drug, it is very effective against E. coli pathogens. The key piece of information missing here that would possibly lead us to a different or wrong result is resistance. So we know that certain strains are resistant to penicillin and certain strains are not. And armed with that information, we can interpret this result as The reason it doesn't work, it's because it's resistant. It's because certain strains are resistant. The drug on its own is very effective. So we are armed with an in vitro diagnostic as a guide both to treatment decisions and to the way we look at those kind of studies. So patient data alone is not enough. We need to be able to have in vitro data backing it up to inform us on what's happening. And naturally, if in vitro diagnostics are so important, the next question is, okay, so why are we not using them? And what kind of diagnostics are there out there? Not so many, I would say. The first and most common and simple one to use is a disc diffusion test. Put two discs of antibiotics, A and B, one next to each other. If they look like this, then they're additive. If they form a keyhole, they're actually synergistic. If they form this kind of kidney shape, they seem to be antagonistic. And if they are completely resistant and there's a gap in the middle, we still call them synergistic. This is what we call a qualitative test. It doesn't give you any amounts, it's not quantifiable, and it's obviously very prone to user bias, right? What if I place these discs a bit separately? What if this circle looks more like a kidney? What if this is just an artifact of culture? So it's very biased and very unreliable, and it's just meant to give you a big picture kind of information. We do have, however, quantitative antibiotic combination tests. For example, time kill assays, where we monitor how a specific strain responds when exposed to single antibiotics or combinations over 24 hours. We take certain growth and survival measurements for every hour. And then from this figure, we try to extrapolate if there is a synergistic or antagonistic effect based on the growth that we observe. And then there is also checkerboard assays, where one antibiotic is diluted in one direction, another one is diluted in the other direction. And then in this 96-well plate, you can find the point where you start getting inhibition in the antibiotic cocktail. And from that information, you can calculate this using some simple math. This is called the fractional inhibitory concentration index, or FICI, where it's basically a sum of the inhibitory concentration of antibiotic A in combination versus its MIC, plus the inhibitory concentration of B in combination divided by its MIC. And there are some limits set that if this sum is below 0.5, then we can call this a synergistic interaction. And if it's above 4, we can call it an antagonistic interaction. So both of these methods are very quantifiable. They give good data. This one is a bit difficult to interpret because you're basically comparing curves. This one is more straightforward. However, they are very expensive to perform, both in the case of reagents used and more especially in man-hours you need to actually do them. So people that do time kills know that time kill is not only because you kill bacteria, but you also kill your own time. So naturally, that is a big hurdle, a big obstacle on why these are not applied as commonly as we would like. And finally, there is also this one called the cross e-test method, where you basically use two e-tests in combination to get the same kind of FICI information you used to get before. So you cross the two e-tests on the point where the MIC of the strains coincide, and then you can get MIC of B alone, MIC of A alone, and MIC in combination. The drawback from this is that it requires prior knowledge of MIC to work. So on day one, you need to do two e-tests to determine two individual inhibitory concentrations for that specific strain. And then the next day, when you know that information, you cross them and you can get the combination. So it takes twice the amount of time, it requires 4 e-tests, and they are not for free, of course. So the whole of the existing diagnostics that we now have available in the clinic, none seem to be suitable for routine clinical use. Either they're unreliable, or they take too long, or they're too expensive and hard to use. And that is kind of the problem we set out to address in a new approach we have come to call Combient. So can we actually create a method that is both easy to use, but also produce quantifiable results when it comes to antibiotic synergy? And in the end, it looks something like this. So it's a small insert that goes in the bottom of a standard Petri dish. How it works is it has 3 reservoirs. You fill every reservoir with a single antibiotic diluted in agar that you care about. You place the insert on the plate. And at this stage, it is completely inert. It sits like this. You can keep it in the fridge for however long you keep standard antibiotics refrigerated. When you're ready to use it, you take out this plate and you pour a layer of agar on top of it. And then the assay is activated and it's ready to be used. And at this point, this handles the exact same way as any normal Petri dish would. You can incubate it upside down, you can streak on it, you can plug it into any automatic plate handling pipeline you have, you can fill it with robots, you can handle it as ever with every kind of way or method you have of handling Petri dishes. The way it's different is that once you seed an antimicrobial suspension on it, the antibiotics that are sitting on the bottom start to diffuse upwards and out into the agar on top. And that specific diffusion is something that is very set, something that we can model using a computer in a way that allows us to predict every single point, both inside this triangle and on the outside of the plate, what concentration of antibiotic it will have. And this kind of information allows us to extrapolate a lot of useful information later on about the strain. So we've put a strain on the plate, we've incubated it, we've waited 24 hours or an overnight, and this is how it looks. Gray is growth, white is growth inhibition in this case. So we see here how it looks on a standard plate. And there are certain points of specific interest. On the blue points, the assay works identical to a disc diffusion. So a single antibiotic, in this case, whatever it is in C, is diffusing outwards, and at some point it is inhibiting growth. So the blue points are actually single growth inhibition points for those 3 antibiotics. The red points that are on the inside are actually inhibition points where 2 antibiotics are combined. So A and C together, they inhibit growth in this point there. B and C together here, A and B there. Since we do know all the concentrations of all antibiotics in this plate, what we could get is Ficky information by just comparing the concentrations here compared to the concentrations on the outside. So from this one single plate in one go, we get information about 3 antibiotic combinations at once. And we can see, for example, that here, A and C, when combined, they seem to be very antagonistic. The C seems to be inhibiting A lot. A and B seem to be synergistic. The action of A seems to be helped a lot by the existence of B, and B and C seem to be additive. So it is even intuitive to read by eye and understand how the results came to be. And of course, the way to compare it is to say that in an assay that usually just gives you the effectiveness of one antibiotic at disc diffusion, instead of getting just the effectiveness of one antibiotic, you can get a measurement of how effective 3 antibiotics are and 3 unique measurements on how combinations act, all in one assay that previously only used to give you one piece of information. And to put things into perspective a bit, if you would like to perform an interaction screening of 5 antibiotics on a single isolate, which is what most hospitals would do, it would require about 640 tubes for time kill assays, 10 96-well plates if you're performing checkerboards, or just 4 Combient plates. So it's a cost reduction for hospitals if you include man hours of about 1,000 to 50 times less. And of course, since it is so simple to use and so easy, you can use it for large-scale screens or to produce this kind of art of antibiotic interactions, if you seem to be more artistic. And the impact of it is twofold. For hospitals, it is now an affordable way to perform interaction testing as part of clinical routine. And for academic labs doing research on these kind of things, it is a paradigm shift on man-hours spent per data point for interaction screening. And we're going to focus on this for a bit. So remember, we talked about how up to 50% of patients with bacteremia, surgical site infections, or pneumonia get antibiotic combinations. So we thought, okay, let's focus a bit on bacteremia and how that is treated in the hospital right now. So we know that approximately 28% of all patients admitted to ICUs suffer from some sort of bacteremia or sepsis, and a further 80% on top of that acquire a bloodstream infection during care. And it is a very dangerous situation because mortality rates are as high as 30% in hospitals of high-income countries. So it's no joke. And specifically, E. coli bacteremia is very, very common. It is the most common cause of a bloodstream infection worldwide, as well as the fastest growing number of cases per year. And E. coli alone accounts for approximately 25% of all bacteremia cases at the moment. And in Europe, and specifically in Sweden, these kind of bloodstream infections are treated with broad spectrum empirical treatments, where a combination of an aminoglycoside with a beta-lactam is recommended as the first course of action against bloodstream infections, especially the suspected pathogen is E. coli. Now, this is starting to change, but it is very much in use at the moment as well. So we thought, okay, combination treatment for bacteremias. Let's look into it a bit further. So we start with a population of 600 clinical E. coli isolates, all isolated from people with a suspected UTI infection. And we thought, let's quantify antibiotic synergy between 2 beta-lactams and 2 aminoglycosides for those isolates. We picked ampicillin and cefotaxime as the most common beta-lactams given, and gentamicin and topramycin as the most common aminoglycosides given. And out of those 600, about 270 were susceptible to all 4 antibiotics. And for those 270, we got the interaction profile for all 4 combinations. This forest of bar graphs is kind of what you get out of this. And I would point out that what you can easily spot is that most of the strains are in the additive area, which is a good thing for this combination. We would have hoped that some of them would be synergistic, but they're not. And unfortunately, some of them seem to be crossing into the area of antagonism. So as a summary result, we actually saw not a single one of the 270 isolates being synergistic, and we detected 5% of them showing an actual antagonism. And this was something that has previously been undetected, because the kind of numbers you need to actually be able to conclusively say this are very large, because it's a very infrequent phenomenon. And this materialized in this study that was published recently, where this screen was actually the largest antibiotic interaction screen of its kind, with 10 times as many isolates as any other screen performed before. And that is important, again, because we were able to pinpoint this kind of infrequent but very dangerous, perhaps potentially antagonistic situations. And it showcases a bit the power of this method, because what could have been a 2-year project for a full academic lab to do the interaction testing for so many isolates ended up being a summer project to collect all this data. Switching gears a bit and taking it a bit further, we see that some strains are antagonistic and some of them are additive. And the first question we want to ask about it is, what could be the mechanism that makes beta-lactam aminoglycoside combinations become antagonistic for some strains? And what could be behind this kind of interaction? And what we noticed is that current assays are actually ill-equipped to handle this kind of specific mechanistic questions on antibiotic interactions. And that is because antibiotic interactions are very many and they fall under different categories. If we take, for example, colistin combined with doripenem, they inhibit parallel paths of the same pathway. So the presence of both antibiotics makes both of them better. And the same is to say for dalfopristin, quinopristin, where they mutually stabilize each other. So the presence of both makes both of them better. However, if you look here, for example, when you combine penicillin and streptomycin, the presence of penicillin allows streptomycin to enter the cells easier. So penicillin is not affected by the presence of streptomycin, but streptomycin acts better in the presence of penicillin. And the same is to say for inhibitor inhibition, where clavulanic acid actually inhibits beta-lactamases and allows penicillin to act better. Clavulanic acid on its own is not affected by the presence of penicillin, but penicillin is greatly more effective if you combine it with clavulanic acid. So you have unilateral interactions where one component of the combination makes the other one better. And you also have bilateral interactions where both components make each other better. And knowing if the interaction you're studying falls under the unilateral or the bilateral ones is a very good starting point if you start to look at the mechanisms behind it. So we went back to the original Combia data and we thought, could we actually quantify this? Could we actually see which antibiotic is acting where? And we realized that within the 3 key value that we were calculating before, this information is there. If you just don't look at the addition of those two, but separate the 2 ratios. So how A behaves in combination with B compared to how it behaves alone could be completely different than how B behaves in combination with A compared to how it behaves alone. So if you just break up the Ficki index into its 2 components, all of a sudden a data set that looks like this, a single value, completely uninformative of how the interaction looks underneath, becomes like this, a 2-dimensional cloud of points, where although it's very obvious that cefotaxime seems to have a completely additive effect to gentamicin, it looks like gentamicin is actually promoting the effects of cefotaxime quite a lot. So this is a very good indication that it is the aminoglycoside that's driving that interaction forward, which again is a very good vaulting point for further studies of antibiotic antagonism. So, yes. So expanding the data to allow better studies is where we're at right now. And we're able to have an insight on unilateral versus bilateral interactions. And that is very key for mechanistic studies, and it gives us the ability to design and control mutant screens that could potentially be very useful. Further diving deeper into the whole mechanistic space, what we know is that when you are in the sub-meg parameter space, so when you're treating with sub-inhibitory concentrations, antibiotics don't tend to behave the same way. And there's nothing to indicate, or nothing that's been done so far to study how interactions behave in sub-inhibitory concentrations. Everything has been done around MIG. So do antibiotics interact in the same way in concentrations below inhibition? And are the same mechanisms responsible for their interactions over MIG as they are under MIG? So these are questions that we're asking right now, and we're waiting to try to see how the sub-MIG parameter space looks like in the combination of aminoglycosides and beta-lactams. So yes, paradigm shift in man-hours and more specific detailed information about antibiotic interactions for academic labs. New tool provides insight for mechanisms of antibiotic interactions. But what about hospitals, right? Let's go back to those. What we care about in a hospital setting is the ability to perform interaction diagnostics as part of clinical routine. And what we care about most or exclusively in hospital settings is actually clinical outcome. We want patients to be better. We want treatment to cost less. We want people to spend less time in the hospital. So clinical outcome. And whatever laboratory measurement we do, in this case, we are measuring bacterial susceptibility to antibiotics. We always want to correlate it to clinical outcome. So we do not care about how this works. We do not care if it is accurate from a physics perspective or from a chemistry perspective. All that we care is, can I correlate the thing I see here to better clinical outcome? Even if it is dark magic, we do not care. What we need to know is, can I translate this information back into something beneficial for patients? Correlates to is the key word here. So if we look again at susceptibility tests, single antibiotic monotherapy tests, there have been decades and decades of a proven track record correlating that testing for susceptibility leads to better clinical outcomes. Being informed when a strain is resistant or susceptible means that your patient is going to be better faster. And there are also golden standards that exist right now, but when you develop a new diagnostic, you need to match or supersede to be able to be admitted in this setting. However, for antibiotic combinations, there is actually none of that, because there hasn't been a test available so far that could be used in this setting to show if in vitro, when we detect synergy or antagonism or additivity, does this mean that our patient is going to be better or worse for it? And that is the question we set out to ask again. So do you get better outcomes if there is synergy between two drugs? Or do you have increased risks if there is antagonism between two drugs of a treatment? And unfortunately, no investigation of the diagnostic value of in vitro interaction testing has been performed so far for the reasons we discussed. But now, with this new test we've developed, that is something that could be feasible. So we're setting out, partnering up with Academiska here in Uppsala and the University Hospital in Lausanne in Switzerland to perform 3 retrospective clinical studies on cystic fibrosis, endocarditis, and osteoarthritis, where we look at in vitro on the synergy profile of the strains based on the combinations they got, and then we look back at patient outcome to try and see, is in vitro synergy or antagonism something that clinics should care about? And this would be the largest antibiotic interaction screen study in their respective diseases, compiling more of 100 isolates for every type. And it will be the first time a correlation between in vitro interaction data and clinical outcome is actually investigated in that scale. Any good answer, or whether or not our ability to quantify interactions in vitro affects patient health and health economics. This is the team so far. Dan Anderson, Ho Che Tang, Roderick Rumhild, Johan Kroger have been involved since the beginning in development of this assay. Lex is the one who produced a lot of the data you see in the beta-lactam aminoglycoside screen. Dione and Sane are working on the mechanistic side of things, and Eunate on the retrospective clinical studies. These are our partners in Lausanne, people we've gotten help from, Uppsala University Innovation, and different funders and funding bodies that are key to this effort. And I'm going to finish by saying this. This kind of method now is under an open beta test for academic users. There's multiple labs already joined, and you get access to this and free analysis in exchange for some user feedback, because we're trying to truly develop a tool that will be suitable for all or most of the studies people want to do with this kind of technology. So yes, if that's something you're interested in testing out or looking into, just drop me an email and I can hook you up, so to speak. So yeah, less than 40 minutes.
Great. Thank you so much, Nikos. That was a very comprehensive overlook at what you are doing, I feel like, and also on the useness of it as well. I do have a couple of questions, but before I ask questions myself, I'm gonna see if anybody already has their hand up and ready to have some discussion about what you just presented, which I think is very, very interesting. Nobody has the question yet, so I know people probably are thinking about it and maybe marinating. Oh, Ingrid has a question. So what's the story behind the idea of the combination disc? How did you come up with this solution?
Yeah, what's the idea behind the combination disc? So we wanted something that was as simple to use as a disc diffusion, because where all other methods have failed so far is that they become so complicated to handle, clinics are not willing to do them. So that's where it started. And why there are 3, for example, in this disc, is just because when you combine 3 antibiotics, you get all pairwise interactions in the same plate. As soon as you start increasing the numbers to 4 or 5, you start missing certain combinations. And it turned out to be a good idea to have it as a disk, because clinicians I've talked to, they say that intuitively they can understand how the data is coming from, because that is a template that we're used to seeing, right? We're used to handling. So that's kind of how that was.
Great, yeah. I was. It feels new but oddly familiar when you have to deal with a plate and you have to, streck colonies and or like cultures. Nazneen has a hand up. Could you please open your mic and ask your question?
Yeah, hi. It was a very nice webinar to begin with. Thanks, Nico. I learned a lot. So I have one question. I probably missed something when you were talking about studying the synergy in patients, right? So how would you take into consideration the variation that you would see from patient to patient?
Yeah.
I mean, so you could have synergy within the patient body, but you could, probably one person would show very different reaction as compared to the other, right? So how would you take into account that?
Yeah. So there's two different questions hiding in there, I think. One is, is the interaction we're seeing in vitro, be it synergy or antagonism, directly translatable with what happens in the human body? And the answer is, I don't know, and most likely not, because pharmacokinetics and pharmacodynamics come into play, and different antibiotics penetrate different tissues in different ways. So it's by no means a conclusive say that I see synergy in vitro, therefore there needs to be synergy in the body. So that's that. And the second part is, yes, there is great variability between patients, the same way there is great variability between bugs, right? That's why routinely testing, the same way we routinely test for susceptibility, is the way forward here, because you cannot blanketly say, okay, these two drugs should always be combined because they seem to have great effect in the clinics. No, it's not like this. It could be that for that specific patient and that specific infection it does, for another one it does not. So case-by-case testing is key in this one.
Sure, thanks for the explanation.
So we have another question here in the chat by Lotlev. How exactly do you know the diffusion of each antibiotic in the disc, and could the diffusion of one affect the diffusion of another?
Yeah. So the answer is you calibrate. So the first time you use a new antibiotic, there is a calibration protocol that is available that you do once, and that lets the pipeline know exactly what the diffusion of that antibiotic is in the specific settings of your lab in the media you use, right? It's very simple. It takes about one plate to do, and you only do it once. And to answer that, does the diffusion of one antibiotic affect the diffusion of another one? The presence of a second chemical would definitely affect how the first one diffuses, right? But if there is a situation, for example, where you have cross-binding, so one drug binds to the other one, then that is indicative of antagonism to begin with. So in a sense, it is both a limitation and an actual feasible result that you would like to see.
Interesting. Yeah, that, and I have a question here in between before I ask the next one that Christian wrote. Both for the calibration plates, where I assume you would probably see diffusion with dyes or something like that. Somehow you can see how they diffuse. How do you do it?
So you use a strain, a specific reference strain for every species that you're interested in, for which you know the MIC. And by know, I mean you're 100% confident and sure that in your hands, this is the MIC you get. That's the point of reference strains.
On a monotherapy.
On a monotherapy, yeah. And then you put that antibiotic, no dye needed. You put that antibiotic into the reservoir and you do a proper assay like you would normally do. And then all you say is tell the software, this is the MIC of that strain, and this is how that antibiotic looks to be inhibiting it on the Combien system. Figure out the diffusion parameters that make this happen.
All right, because that follows up with Christian's Gill question, which is, since there is no gold standard to compare your disk synergy testing, what are you comparing your results to for validation on the method?
Yeah, so when it comes to susceptibility, that is not something we're doing at the moment. We are validating only the results about the interactions. And we're validating them against time kills and checkerboards, wherever possible. So both of these methods, since there is no clear golden standard. And so far, both in the first paper and in the subsequent paper with a big data set, they seem to be coming up with the same answer.
All right. Lotliev has a follow-up question. Do I have to make the antibiotic solution myself?
So if you have an antibiotic stock that you use in the lab, the answer is yes, you dilute it in agar yourself. We are also working at a version of this where it will be pre-infused, and all you have to do is put the next layer of agar on. But at the moment, for the beta version, yes, you make an antibiotic stock using the reagent you have in your lab.
That's also why you have to calibrate, I guess, by the way that you,
And in a sense, some of the feedback we've gotten is that absolutely no, we would never want to use somebody else's reagents because we don't know if we can trust them. And it's a matter of what suits you best, I guess.
But when you envision, this is now, in a beta testing and it's academic use, you are saying how much hours of work and effort it saves in the lab when you want to study combinations and in different isolates and everything. But when you envision in the future this as a test that could be provided for the clinics, would you see these plates as being produced already with certain combinations in the plates that is all standardized? So the labs at the hospital don't even have to do calibrations or anything, and it's all being produced within ISO standards and quality control. And what you actually are giving them is already plates that have antibiotics and agar where they can plate directly, right?
Yeah. So both yes and no. Clinical microbiology labs in hospitals are a specific breed of their own. So yes, they need to abide by ISO rules, but at the same time, they can do their own personal validations for technologies they want to use in their own way. And there are certain labs that would definitely prefer having just a plug and play, everything is ready, just put it on a plate and you're done method. And there are others that have already asked, no, we make our own, we impregnate our own discs. We have our own stock solutions that we trust when we do broth microdilutions. We would like to use this with those reagents that we have available. So both, depending on what every lab likes.
Before I continue asking you some things, I can just say to everybody that we still have some time. So you have more questions, feel free to open up your mic and ask them or write them down. But I have a question regarding accessibility of the process. For example, for the labs, do they just have to do they can use any equipment to take a photo of the plate, or does it have to be standardized somehow so the software can read it?
No, absolutely anything you have. I use my phone because I disinfect it and I put it in the lab. You can use any sort of plate imaging thing that you have, absolutely anything. There's even a lab that decided to use Polaroid snapshots that they then scan to do
that
this.
That is very expensive way to do it, honestly.
That's what they had.
That's very, so it's just any input will work on the software with it when it comes to the photo. That's cool. All right, there's no more questions here. So I do have some. So on the work done so far, what has been the most challenging part on developing this? I could envision many different ones, but I want to see, like, what do you think has been the hardest part of all this process?
The hardest part, yeah. So the hardest part is that when you start developing something, you do it on certain very well-behaved strains and certain very well-behaved antibiotics. But once you start including a bigger list of substances and a bigger list of strains, you start bumping into new problems that you did not expect. And you need to compromise the technology you had from the beginning to account for these new parameters. So expanding the usability of it to the point where it is now, where most compounds can actually work with this, most strains can actually work with this. That was the most challenging part, I would say.
M. Klintstedt is asking, for how long is the plate stable after adding the agar layer?
The answer is they are not stable when you add the agar layer. So they activate the moment you add the agar layer, but you can use them within the same workday where you do this activation. So if you activate them in the morning, you can use them until that night with expected results. So you activate them, use them, and then you incubate them on the same night.
All right. I have a question regarding the application of this in the hospitals. As you were saying, clinical microbiology labs are very set in the ways they work. And we know from talking of other people that trying to bring innovations into the clinics, that sometimes changing routines and adding a different way of doing things is difficult. Have you done some preliminary work with people at hospital labs about how would this be included in their routines, and if it's feasible that it would be an easy take up by the hospitals?
Yeah, we've done a lot of that with our two partners, Academiska and KUF. And the answer is, for chronic diseases such as osteoarthritis, cystic fibrosis, endocarditis to some extent, so not acute, not bacteremias, the hospitals are willing to try new things, basically because the cost is huge. You have it all your life. You go back for treatments again and again and again. So that's an easy entry there. And then for acute cases, when you stumble upon multi-drug resistant strains, that's also an area where any sort of new kind of information, no matter how unvalidated it is very useful. So we're actually running a test right now to see, could this be used for combination treatment for multi-drug resistant gram negatives? Where if you can find any cocktail that works a tiny bit better, you're very happy. So
yeah, but I guess the problem there is the time, right? Like you just running out of time and things have to be done very quickly. All right, we have here Darmet is asking, have you tested the method using combinations of combination drugs, for example, beta-lactam plus beta-lactamase inhibitor with another combination, for example, sulfas with TMP, I guess?
Yeah, so putting a beta-lactam on one reservoir and a beta-lactam inhibitor on the other, I have done it, and you get extreme synergy. But the inhibitor on its own is not, it's not an antibiotic. It does not inhibit growth. So in a sense, the acid doesn't work the traditional way. And then if you want to consider the beta-lactam inhibitor as one drug, let's say piperacillin tazobactam as one drug, then there's two ways to do it. One is you impregnate the inhibitor in the entire plate. UCAS, for example, wants a set concentration of inhibitor for the test you do, or you put the inhibitor together with a drug, together with a beta-lactam, and let them diffuse at the same time. So you have a fluctuating concentration of one and the other.
I think he meant both in one well. So like the combination that is given in one well, and then the other combination another well.
Yeah, that you can do, and you treat it as one drug.
Have you done it?
At the end. Yeah, it looks like it's one drug.
It works, and you can use the same model and everything.
Yeah.
Interesting. Christian Hill has another question here. What are the minimum and maximum number of combinations you have studied using the disk diffusion method? Have you utilized beta-lactamase inhibitor as one of your combinations? This is the same as before. And were any complications in correlated synergy, since the amount of inhibitor is not always in alignment with the clinical exposure?
Yeah, so the maximum number of combinations we've tested, that's a good, I don't know how to answer this. So far, the way we've been using this, maybe for a single screen, 8 different combinations as part of the same kind of predictive treatment. If we're talking about how many combinations have we tested since we started this, probably 30 or 40 or 50 if you cross different strains. And then for the rest, yeah, it's a limitation. If you want to use a already established cocktail like a beta-lactam and a lactamase inhibitor, you will get two different results depending on if you let the inhibitor in the reservoir or if you impregnate the entire plate with it. And you will get different results when it comes to susceptibility. But when it comes to interactions, those differences average out. Remember, because you divide the concentration it inhibits in combination with the concentration it inhibits alone. So those are not so obvious problems when you're just looking at the interaction of two antibiotics.
Mm-hmm. He says, that's great. Yes, I meant how many at one time. Thank you.
Yeah.
Great. And I have another question. Towards the end of your presentation, you were talking about how you can use this method to understand unilateral versus bilateral effects of antibiotics with each other, basically. Maybe I just missed some details or I couldn't grasp all the new information at once, but do you see that there is one way systematically better than the other for the interactions between antibiotics?
How do you mean? Is unilateral better than bilateral? Or?
Yeah, like systematically, can you say is unilateral better than bilateral? And then you can quickly say, okay, these two are unilateral. It's better if we use a bilateral combination or something like that.
So no, there's no one that you can say it's better, because better is a clinical thing, right?
Mm-hmm. Mm-hmm.
So from a lab perspective, from an academic perspective, the first thing you want to figure out when you try to look at why are those two behaving like this is which one is the driving force behind this interaction that we're seeing. So bilateral ones are indicative of a different mechanism than unilateral ones.
Mm-hmm.
And in a sense, it's easier to figure out the unilateral ones because you know, oh, this antibiotic makes this one better. Therefore, that must be why. Bilateral ones are a bit more complicated to figure out. But yeah, knowing which one is the driver and which one is the driven is a big first step.
Mm-hmm. This is the first time that this kind of investigations on interactions has been done?
There are others who have looked at unilateral versus bilateral interactions by looking at this way, but not to this scale, at least.
Mm-hmm. Very interesting. All right, we're almost running out of time, even though you finished up a little bit early, but it's very interesting. I only have a general question. I don't know, this presentation and of course your work based in Lausanne and based in Sweden is very much on the effect and use of antibiotic combinations in the context of developed countries and high-income countries. But do you have some data on the use of combinations in low and middle-income countries and how using combinations might actually help or not help a clinical outcome in that setting?
Yeah. So since the beginning of this, our goal was to develop something that could be open to low-income hospitals and situations as well. So no expensive instrumentation needed, no expensive assays, because it needs to be available for not hospitals with big budgets. And unfortunately, the correlation usually is that environments with lower resources are environments that also tend to have high instances of antibiotic resistance. And that comes, in a sense, directly afterwards, high instances of combination treatment as well, because of trying to come up with better ways to account for resistances, right? So those numbers for diseases, the ones we talked about, are the ones that are treated with antibiotic combinations worldwide. But there are others that are treated with combinations in some countries and not in others. So if you stop looking at high resource hospital environments, combination use goes up.
Mm-hmm. All right, yeah, that's something good to have in mind. Anybody else have any questions? Doesn't seem like it. If not, then I'm going to close up this webinar. Thank you so much, Nikos, for being with us on a day before a holiday day.
Thank you for inviting me.
Before we sign off, I just want to remind all of you that we are going to have our last seminar/webinar of the year, the first Friday of December, 2nd of December, but with the special thing that this time we're going to have it both inside and online, because we have an invited speaker coming from the UK here to Uppsala. So if any of you that are still here with us are in Uppsala, I would really welcome that you guys come on site, because we would like to be there with the speaker. But if you are from abroad, you always are also welcome to join online as well for that webinar on December 2nd. Before that happens, we also have the Uppsala Antibiotic Days conference coming up on 24th and 25th of November. I know that, but for a fact that some of you have already signed up for that. We are full house at the moment, but if you have not signed up and you have interest to come to our conference, you can always send us an email to be put on the waiting list in case someone cancels. I leave the link to the website for the conference and the chat as well, if you want to check out who the keynote speakers are. We're going to have a very nice program with a lot of different topics in IMR, so we're really looking forward to that as well. And with that, I close up today's webinar. Again, thank you, our speaker, and thank you all of you that have been here with us for today, and see you at the conference or on the next webinar.